So let's start with targeting IgE. What do we know about, omalizumab has now been used for more than 15 years, and in fact, IgE is an important biomarker to define. Probably allergen-specific IgE is much better than total IgE. It's actually definitive to define allergic phenotype. Now, the level of IgE is important to define the dose we need to target patients with allergic asthma, but it's not a predictor of response. It's important to keep that in mind. What we know is that omalizumab targets circulating IgE, and thus it blocks IgE and prevent it from tagging on the Fc epsilon receptor, and thus release of mediators from the mast cells. Well, this was the simplistic thought that we had, but now we know that anti-IgE may have other effects, including the decrease in Fc receptors on other inflammatory cells. But there's some good data, emerging data, that they may have effect on viral clearance and thus may reduce viral-induced exacerbation, but also may have some effect on the incidence of asthma. It's been now tested in a large NIH study. One of the studies we performed with omalizumab was a large US study on patients who are uncontrolled asthma with history of exacerbation. And we found that patients have 25% risk reduction in exacerbation when omalizumab were added to high dose inhaled steroid and lava. But also in the same study, we also looked at asthma quality of life, and we looked at the biomarkers, which I just showed you earlier. There are several now, since the drug has been there in the market for a long time. We've utilized it from different countries around the world. There's several real-world effectiveness study, and of course, long-term safety study. This is one of them. Again, I won't dwell in details, but again, showing that sustained effect is there in real life. There are lots of questions with anti-IgE. How do I know the patient is responding? How long do I keep them on? Do I really need to keep giving the patient every 2 weeks? It's either every 2 weeks or every 4 weeks, depending on the IgE level. These questions are still not fully answered, but I think we are working on them. So it's going to still be there. Obviously, many of the allergic phenotype patients also have eosinophilic phenotype. And so the question that always comes to mind, and including myself, well, if I have somebody with allergic asthma who has high eosinophils, do I use something that targets eosinophil, or do I use an anti-IgE? Or maybe in the future, a combo type of drug may be needed. It's something that may need to be explored further. To summarize, what we know about anti-IgE is that there's definite effect on reducing exacerbation, improving quality of life, and there are studies showing decreased healthcare utilization. The studies were done on less severe patients than those done with anti-IL-5. If you look at meta-analysis, there is an effect on reduction in oral steroid dose, but it was not systematically studied as the studies that were done with anti-IL-5 in large trials. And there's been lots of safety studies, long-term studies, and also real-life safety studies as well. Well, with that, I'm going to shift gears to Ray, and he's going to walk us with the eosinophilic asthma and what do we know about it, and how do we target eosinophilic asthma.
Great job, Nick. Really appreciate it. He just covered 15 years of monoclonal antibody therapy in severe asthma as we know it. And I think I want to highlight a couple items that Nick mentioned that's really important. What is the workup that you need to do for severe asthma? You need to do really 4 tests. You need to measure eosinophils in the periphery. You need to measure total IgE. You need to measure specific IgE. And I'd also say pheno is going to be very helpful in discriminating patients that we may choose to treat. The other concept Nick brought out, which was really important for you to understand, is something called pharmacodynamic markers. A pharmacodynamic marker for you as a clinician means I engage a target and I know the target's been engaged. What do you mean? Well, if I take an antibody that wipes out eosinophils in the periphery and I measure a blood count before I give the antibody and after, and the eosinophil goes away, I know I've engaged a target. Now, I didn't answer the question, did asthma get better or not? But I know the target's engaged. Then I asked the question, did symptoms improve? Quality of life, functional status, FEV1, exacerbations. Why is that important? Well, if I took out all the EOs and none of those other outcomes worked, guess what? The eosinophil is not a major component of that patient's asthma. We have no other drug as pulmonologists that allows us to determine pharmacodynamic markers typically. So this is a really hot time.